All right, spinal cord injury. The concept is the same as intracranial regulation. In fact, this is in the same category. So this is the extension of your central nervous system. Um, the CNS ends as it exits the foramen magnum. The only opening in your skull at the base of the skull. So now it becomes the spinal cord. So if there are injuries in the CNS, it will be reflected on the spinal cord as well. This one though is just talking about spinal cord injury. So we are talking about the mechanisms of injury, which most common are the following. We have hyperextension, that would be somebody giving you an uppercut. Hyperreflection, somebody hitting you with a aluminum bat on the top of your head that will make your neck hyperflex down. Rotation, somebody twist your neck, and then vertical compression. So let's say you fell from a 10-foot high wall, for instance, thinking you can, you can manage that. Or jumping down a pool and then finding out there's no water. Or penetrating injuries, either you were stabbed or shot in the spine. The spinal cord is made up of the same nerves, neurons, which are made up of axons and dendrites. They extend down the spinal cord, starting from the cervical region down to the sacrum. So if the brain suffers concussion, contusion, compression and tearing, laceration, transection, etc., it's the same mechanisms of injury affecting the cord. Just like the brain, which is encased by the skull, the spinal cord is encased by the vertebral column. So if you suffer any fractures of the spinal column, for instance, the vertebrae are broken or are out of alignment, then it will cause injuries, direct or indirect injuries to the spine. If you remember in traumatic brain injury, wherein you had primary and secondary head brain injuries, you can also have primary and secondary injuries of the spine. So same thing. So there may be injuries resulting directly from the cause of the damage, from the penetrating or compression injuries that led to the spinal injury. It can also there can be secondary injuries that form after the primary injury, meaning after the initial injury there will be resulting swelling, bleeding, and therefore, because the spinal cord is also encased in the rigid vertebral column, it really can't expand. So as the swelling goes, it's exactly the same as what happened in traumatic brain injury, wherein there was um, kind of like a compartment syndrome occurring. So read the rest here, how the signs and symptoms form, because of course the spinal cord is the pathway for your sensory and motor responses, meaning although your muscles are not affected in any way, the skeletal muscles, I mean, because the spinal nerves along the spinal cord are now damaged, this will render your skeletal muscles useless now because there is no more stimulation. Okay, so look at the last sentence here. So therefore, if this portion of the spinal cord is now damaged, then there will no longer be messages carried to and from the skeletal muscles. So therefore, your skeletal muscles can't function anymore. As I already said, there are two injuries here, just like in traumatic brain injury. There is a primary and a secondary injury. And this is a nice thing to know that the spinal cord does not have to be cut in order for you to have loss of sensory motor function, just like in secondary injury in TBI. So even though your spinal cord wasn't physically lacerated, the resulting secondary injury brought about by the swelling and increased interspinal pressure that results, which will now compress not only the nerves but the blood flow along the spinal cord, because there is a compartment syndrome occurring inside after the injury. So that will lead to the loss of functioning. How much damage there is or how much loss of sensory motor function will depend on the level, which is now the next topic. I will not test the spinal cord syndromes, which are part of the incomplete injuries mentioned here. Complete injury, that's simple because there is permanent loss of and permanent and complete loss of motor and sensory function below the level of injury. Incomplete injuries, though, it's only affecting parts. Again, I'm not testing it, but I'll just demonstrate one. For instance, look at central cord syndrome. So it doesn't result in total or complete loss. So let's say central cord syndrome, look at the manifestations. Its only manifestation is the patient will have greater loss in the arms and legs, bladder, and variable loss of sensation, meaning the other parts, both sensory and motor, remain intact. Do you get the difference? So, whereas complete, meaning let's say you have, look at this picture right here. So let's say you have complete spinal cord injury of the sixth cervical area right here. So that means you will have difficulty breathing and then total loss of sensory motor function below below C6. Whereas if you have incomplete syndromes, so let's say even though you had C6 compression, for instance, if it is an incomplete injury, it won't result in total paralysis or loss of sensation. Okay, there will be just parts of it, or in this one, for instance, look at Brown-Séquard syndrome. This one will only have one side. Okay, either ipsilateral or contralateral, depending on which spinal nerve is affected. What is testable though is this one, table 37.6. First, for medical, for diagnostic purposes, of course, this will only be done with an X-ray or a CAT scan in order to determine where the injury is, which level of the spinal column. So these are the functional loss depending on the level of injury. So I will have you answer questions which say, let's say I tell you the patient has C7 or C8 spinal cord injury. The question will either be, I'll ask you for the symptoms, okay, which functional loss will be evident in this patient, and I'll give you actions that they cannot do, or I'll ask you, I'll give you the patient's ability, sensory motor ability on the stem, on the question stem, and then you identify which level of injury the patient most likely have. Any question?
No.
stare at this table for a while. So let me know which patients are still able to use um, a regular wheelchair, a wheelchair where you have to push yourself around.
T1 to T5.
Okay, let's say the minimum.
Hmm. C7, C8.
C5 to C6.
Okay, so because this one still has gross arm movements,
Mm.
although it may be weak, the patient may not compete in a Olympics, but at least they can push
Move.
themselves around, right? So it's always the minimum. So of course, if it's below C5, then they can, all of these patients below that can definitely move themselves around, right? So that's an example of a test question. Treatment now. So always equate this back to traumatic brain injury because this is simply an extension of the central nervous system. Um, First statement first, so let's set our expectations straight. There is no way to reverse spinal cord damage currently. Okay, there are research. You can go on YouTube. There's new research, but those research involving robotics and artificial intelligence don't reverse spinal cord damage. They do restore the patient's movement, meaning with the assistance of um, electronic prosthetics, no robotics, for instance. They can restore movement, but they do not reverse spinal cord damage. Okay, so that still is a long way from us, meaning we can't grow nerves. All right, currently we cannot grow um, spinal or cranial nerves. Okay, the technology is not there. So our treatment still remains. We support ABC. You've already finished shock during the first module. You know that this thing is the cause of neurogenic shock. Okay, the reason is, although this is not the central nervous system, this is the pathway by which those signals are sent to and from the brain. So the brain is intact here. We have total control. The brain has total control, but then the pathway by which it sends those signals is unavailable anymore. So our problems are the same. So we have ABCs here as our priority. Patient will have, because remember that sympathetic responses have to travel to and from the spinal cord. So there will be a problem here with sympathetic responses. So first is with ABCU. So if needed, we intubate the patient. Next is the supporting the hemodynamics because there is loss of sympathetic stimulation right here, or at least reduced. Patient will have um, the arrhythmias that result here are Brady arrhythmias versus tachy because again there's no sympathetic stimulation, so we're talking about bradycardia, sinus bradycardia, or even uh, uh, asystole. Okay, so the patient will have hypotension, decreased vessel tone, meaning there is no vasoconstriction here. The patient will have vasodilation, which is the nature of neurogenic shock, and therefore cardiac output suffers. So how do we treat that? First is IV fluids, then vasopressors. You have a list of vasopressors here, 37.7. Most commonly used is dopamine, epinephrine, or epinephrine. Uh, Norepinephrine is levofed, which is very commonly used, um, and inotropes. So that is usually enough to increase cardiac output. So the fluids there will be crystalloids, which is either NS or LR. Um, Colloids will be your dextran, blood transfusions, including plasma if needed. Here are your vasopressors. Again, they are summarized. I mean, they are listed in table 37.7. The problem with this is, um, look at dopamine, for instance. So it dilates renal, mesenteric, and coronary arteries. However, it does cause peripheral vasoconstriction. For some of these drugs may lead to decreased blood flow to the other organs, because as you see here, dopamine increases central perfusion. Heart, of course, will once you have increased cardiac contractility, so this will prioritize blood flow to itself, the lungs, and the brain. This will lead to the other organs, specifically GI, renal, um, well, that would be the rest of the organs, GI, so that will include the pancreas, the spleen, the liver. All of those may have decreased blood flow because of the vasoconstriction that results. So that's one side effect of these medications. Unlike before, older editions of the textbook, I remember, still included steroids to decrease inflammation. If you remember, in brain injury, we did that. We gave uh, dexamethasone, not so for spinal cord injury. So this one is no longer recommended. Part of the first aid is, of course, immobilization. So most injuries result in a fracture of the spinal cord. So it's either your spinal column, I mean, any part of your spinal column, but if it involves the cervical or high thoracic injuries, the patient will have to wear a traction device. The principle here is still skeletal traction. Who remembers skeletal traction in the musculoskeletal fractures? You guys still remember?
Like, remember what specifically?
The principle of
Like box
traction. So let's
traction.
say,
Yeah.
yeah, box traction. We had that was a skin traction, right? Then we also had skeletal traction. So what's the purpose of traction?
Immobilization.
Well, in this instance, yes, but why traction though? Because traction always involves weights, right?
Yeah.
So
Reduce
we put,
muscle spasms.
right. So yeah, so we pulling. The traction is pulling. So why do we need to pull either the skin or the skeleton? Why are we pulling it?
To align it back correctly.
All right. So for purposes of realignment. So let me try to illustrate. So if we, all right, can you see a whiteboard?
Yeah.
Yeah, I can see it. You don't have
Okay.
nothing on it yet.
All right. So let's say this is a skeleton. Okay. So it's broken like this.
Professor, I can't see it.
Professor, I can't see it either.
Me neither.
Just your twisty. There we go.
Okay, I can see the textbook. Nope.
Uh,
Mm.
It says whiteboard is in progress, so nothing's on it.
Right now. You can see it now?
For now, only members of the org can participate.
How do I show this damn black whiteboard? How about now?
Oh,
No.
No.
Still can't see it. How about now?
No.
Okay. Let me try something. You can see the book, right?
yes.
Okay. You see this, the halo traction? Yes. Okay. All right. So let me try. Oh, okay. You can see it now, the whiteboard?
Yes. I can.
Yes, I can too.
Yeah.
I can see it.
It's just a bunch of recognized causes, etc., right? Okay, so here's the fracture. Okay, so let's say this is a bone. This is the break right there. So when we do traction, what we're doing is, of course, there's muscle there. So there's tissues there. So that's the broken part. And let me draw this better. Okay. So a fracture that needs traction would be, because let's say you were hit by a truck. Okay, so the bone is probably broken like that. Okay, so it's not in alignment anymore. So if we pull this, so we put either skeletal or skin traction, we pull it with the patient will be providing the patient's own weight. The upper body weight will be providing the counterweight, and then we add weights here. You can imagine, right? You've seen traction either in pictures or in actual clinical.
Yes.
Okay.
I did.
Yeah, so there's a weight there. The patient's weight will be the counterweight. And then we add weights here. We add weights at the other end. So if there are two weights now, weights here, weight, patient's weight there, so this will pull and align the spine back, or this, in this instance, align the bone back, because you're pulling up there and then also pulling here. So this will now realign the bone. So imagine if this is now the patient's spine. So we have, this is Din's. Okay, so Din's spine is broken. It's supposed to be like that, right? So this is his vertebrae. So if this is broken somewhere here, the halo vest will pull. So we put a halo and then we have the post here, and then two more posts on the outside, and he'll be wearing a vest. So what it's doing is we'll put the weight here, so the patient is in bed. So this is the bed. There will be weights hanging right here. So we'll have the weights hanging here, so the patient still has the counterweight. We have weight here, weight, the patient's own counterweight. So this pulling, the traction will pull his spine up, realigning it, if
Mhm.
that makes sense.
Yeah.
Okay.
Professor,
Yes.
is that constant?
Yes, the patient will be wearing the halo vest for a few weeks, um, until our x-rays show that the spine has already been realigned.
Mm.
Of course, this is skeletal traction, so the same care with any other skeletal traction. So the halo is drilled into the skull. So these are titanium screws. So you have to provide pin care sites here. So there will be four. There will be two more screws on the back of the head. So you will do peroxide rinsing. Okay, so you do peroxide, and you may have to put a betadine ointment around there, and then just put a dry sterile gauze around it, and then do that every day, at least once a day, or as needed. So let's say it gets dirty, then you clean it again. The patient wears this vest for 23 hours a day. It will be removed um, for for changing clothes, skincare, or when you do CPR. So let's say this patient goes into cardiac arrest, then you have to remove the vest as well, because you can't do chest compressions with that thing on. Okay, spinal shock. There are two complications of spinal cord injury. One is, of course, the neurogenic shock. The other is called spinal shock. Spinal shock is not the same as neurogenic shock. Spinal shock is a temporary loss of sensory motor function right here. Temporary, complete but temporary loss of sensory motor function below the level of injury. The problem is, though, we don't know when this thing resolves, and it's hard to distinguish from whether this is from a complete or incomplete spinal cord um, loss of sensory motor function. The good thing about spinal shock is this is temporary. Again, the doctors can't determine whether this is the patient's loss of sensory motor function is spinal shock or a permanent um, loss of function. Okay, so all you can do is just hope that the patient is just having a spinal shock instead of permanent loss of function. Neurogenic shock, we already know, so I won't discuss that again. Autonomic dysreflexia, and this will be the last topic for the final. This thing occurs either immediately after the spinal shock subsides, right here, or it will occur after the first year of injury, meaning the patient is already home, they're already done with rehab, they're living their relatively new life. Okay. So this is the pathophysiology involved. Thank you for reading, Ms. Tajira. You want to unmute yourself? Hello? Hello, guys. Are you here?
Yeah, man.
Yeah, we're here.
Yeah, what-
Yeah.
Anybody please read the pathophysiology? This one.
A strong sensory input such as pain, distended bladder, rapid temperature changes, infection, or a full rectum is carried into the spinal cord via intact peripheral nerves.
All right. So what happens is, again, this either occurs right after the time of injury or after the first year. Meaning what's happening, especially after the first year, because this is the most common. So often, statement reads here, it most often occurs after the first year of injury. So what happens after the first year of injury? Do you still have the acute injury, or has everything healed and you have scar tissue and everything?
Um, I'm thinking not if it's gonna happen. If it's gonna happen a year after injury, but
Okay, so this is now after, obviously after the acute episode. So the patient is now back home. Is now adjusting to the changes, on a wheelchair if they can. So what happens is some parts, not the entire spinal cord. So some parts will have some healing. Okay, so there will be intact peripheral nerves because we didn't sever the entire spinal cord. So there are some areas that are intact but won't completely um, result in restoration of function. Meaning there are just some areas that are still left intact, and these sensations here: pain, distended bladder, rapid temperature changes, infection, or so most common are the following: pain, yeah, full bladder or a full rectum. I've felt a full bladder. Okay, I've never been constipated, so I don't have a full rectum. I get diarrhea a lot, but um, I don't know what constipation feels like. But I do know that I cannot ignore a full bladder. I don't know about the rest of you guys, but can you do that? Can you ignore? I've also never felt um, pain for other than acute pain every now and then related to the diarrhea. Um, but can you ignore these sensations?
No.
No, they will gnaw at you, right? Especially if you're stuck on a train, for instance. A train's not moving and you had to go. All right. So your mind will always be on these sensations. Okay, you can't really ignore them. So these are strong sensory input. So these sensations, because they are so strong, they manage to go up the spinal cord and reach the brain. So this will trigger a massive sympathetic response. And you already know what the sympathetic response is, but think of it as a sympathetic response on steroids. Okay, so this is really massive, causing the following. And this is not in any way indicating that you have been healed. Okay, these are just reflexes. That's why they call this autonomic dysreflexia. Okay, so this is a reflex response. Okay, not the return of function. Again, in no way does this mean, oh, the function is returning. No, this is just a reflex discharge. Okay, so think of a massive sympathetic response. So we're talking about increased vasoconstriction here. Um, what else? So that will increase your blood pressure. Okay, and of course the vasoconstriction will cause your skin to be pale. You have diaphoresis. All right. So these are the symptoms. Again, the triggers are the following: pain, distended bladder, rapid temperature changes, full rectum. And is Travis here?
Yeah, I'm here, Professor.
Okay, Travis, what other sensations would you consider strong sensory input in your body? Like um, uh, you can't ignore it.
Um,
What if somebody steps on your testicles? Would you consider that a strong sensory input?
yeah, that might be sensory overload.
Yeah, that would also trigger a massive sympathetic response from you, right? I
Mm-hmm.
would think. Yeah. What about ejaculation or orgasm? Are those strong sensory input?
Yeah.
Yeah, very. So that one though is the pleasant strong sensory input, and then the pain here is the counterpart. So pain is also a unpleasant strong sensory input. So would you say that those other examples that I mentioned are also going to be triggers?
Yeah, I
Because your
guess.
book only mentioned pain, distended bladder, infection, or
Full rectum.
obstipation, right? So we still have other strong sensory input, some pleasant, some unpleasant, right? So consider those because your textbook did not mention them, but other textbooks do mention exactly those that I have told you. So other triggers would be um, orgasms, ejaculation, testicular, I don't know what to call that, testicular compression, right? Because remember, what are these patients' profiles? Are they walking like you and me?
No.
No. Look at this. If because autonomic dysreflexia occurs in 80% of patients with T5, T6 level. So are they walking?
No.
No, these are paraplegics, right? Paraplegics, quadriplegics. So can they feel below their waist?
Nope.
No.
No. Can you feel that you're already sitting on your own testicles?
No.
No.
No. So this is what I mean by testicular compression can trigger this, and testicular compression can occur because you have absolutely no sensation below the waist. So it's important for these patients when they transfer from bed to wheelchair that they take care to make sure that the package below there is in the right place. That you're not sitting on it. So what will the patient's manifestations be? All right. So the patient will have bradycardia. That's one. And then the patient has manifestations of severe hypertension, which is severe headache, um, um, pallor, and diaphoresis below the level of injury, meaning you won't see the diaphoresis up in the above the injury. So if it's T5, T6, so you won't see the diaphoresis above the nipple line. Does that make sense? Hello.
No. Do it. Say it one more time.
Okay. So the manifestation, specifically the diaphoresis here and flushing, um, okay, the diaphoresis and flushing will be, no, sorry, I got it mixed up. So the diaphoresis and flushing will be above the level of injury, and then you'll have pallor below the level of injury.
I figured that much.
Okay. Here, don't be confused about bradycardia and tachycardia. I don't know why they put tachycardia, because the all the textbooks say for autonomic dysreflexia there is bradycardia. So the heart rate here is below 60. Okay, but there is severe hypertension. So these are your signs. So if the patient has any of these signs, a paraplegic who presents like this, so they have severe systolic hypertension, bradycardia, the diaphoresis, of course, this will also trigger nausea, vomiting, because if you have a severe headache, that's what happens, right? It makes you nauseous. So again, autonomic dysreflexia, is this a life-threatening condition? I mean, the blood pressure here is 230 or higher. It's never below 200.
Yes, it's like that.
Yes, so this is an emergency. So the patient, again, who is at risk for this?
Spinal cord injury above T5 to T6.
Okay, so we're talking about every paraplegic, every quadriplegic patient is at risk for autonomic dysreflexia. The problem is, are they prone to these right here? Especially the bowel and bladder problem. Because
Yeah.
no signals, can the bladder contract?
No, they're not.
And can there be peristalsis in the bowels, in the GI tract? No.
No.
There's reduced peristalsis. There is no bladder contraction. So that's why these patients have to self-cath.
So I
Okay?
didn't understand the question. You said they prone to this? These
Yes.
patients?
Uh-huh. Are they prone to these triggers right here?
Okay.
Yes, they are. Because let's say
Yeah, I was just
you're
making.
you're a paraplegic. You cannot pee. So you have to straight cath 4 to 6 times a day.
Mm-hmm.
And so let's say you forgot, or let's say you go party, because these patients still live life. I mean, they're paraplegics, but they're not dead, right? So they go party. I mean, look at Lieutenant Dan in Forrest Gump, right? Lieutenant Dan, did he stop living life?
I mean, yeah, he was spiraling out of control, but he was
Yeah,
party.
he parties, right? Yeah, he drank a lot. So does he need to still only self-cath himself 4 to 6 times a day, or more often now? Because you're drinking alcohol
More often.
more often. So what happens is this: if this patient still keeps with the 4 times a day, and then not knowing, how many cans of beer he's already had. So of course that will increase urine output.
Right.
But can he feel or sense the distended bladder?
No.
No, nothing. Because remember, they can't feel anything below the waist.
Mm-hmm.
So when these things happen, this will trigger, of course, a strong sensory input and then cause autonomic dysreflexia. The next thing they know, they already have the severe headache, and the diaphoresis. And then if they're not aware, then they'll die. They'll have a hemorrhagic stroke. Of course, this is a paraplegic. So again, the most frequent cause is a full bladder or a full bowel. Others are tight restrictive clothing, GI disturbances, DVTs, a pressure ulcer, because the pressure ulcer, although you can't feel the pain, is a pressure ulcer painful?
Yes.
Yeah, they just can't feel it.
Yeah.
So infection, which they are again at risk for, because they have to self-cath, so that increases the risk of infection, although not as high as if they had an indwelling catheter. Um, Shoes. The shoes here have to be tight fitting, or lying on sitting on a hard object, or any minor injury. Okay, so those are the other triggers. So how do we care for this patient? Because this is an emergency, there's always a chart for that, or a table. Um, so since you cannot administer the antihypertensive drug right away, because if you look at the list here, which one would be your first action? Of course, we monitor BP, because otherwise you wouldn't know that this is autonomic dysreflexia, right? You have to check the vital signs and the heart rate. So you see severe hypertension and bradycardia, and the patient having paraplegic, then this would tell you, oh, this is autonomic dysreflexia. So between giving the antihypertensive drug, which is IV, versus this one, which one would you do first?
Raise the head of the bed.
All right. So you can easily sit the patient up. Of course, these are paraplegic, so there's no way they can be standing up. So you sit them up. Okay, you can't. There's no scenario where they're standing up and then you sit them down. Loosen. So these measures here that follow are, you're looking for the trigger. All right. So whichever one applies. So if the patient obviously is not wearing anything restrictive, then your next check would always be, or your first check rather, would either be the bowel or the bladder. But I don't know about you. I'm not gonna go in there, um, going up the rectum first, right? I mean, between checking the bladder and the rectum, which one would you do first?
Bladder.
Yeah, it's easier to palpate the bladder to see, but plus it's the most common anyway. But of course, it could also be um, the fecal impaction. So there's no way around it. You have to go in there with gloves, of course. But that's an option, use your judgment. Okay, so if you don't want to wear gloves, I mean, that's fine. Any question on autonomic dysreflexia? So if it happens once, this can happen again. And your severe hypertension here doesn't um, uh, prevent seizures. Of course, severe hypertension will cause increased ICP, so that might trigger a seizure as well at the same time. And because the patient is paraplegic, at the same time they may have a DVT, throw a PE, or an MI. Here's the hemorrhagic stroke, and then death will follow. So after they've had this one, of course, this will become part of their medical record that they experience autonomic dysreflexia and therefore is at risk for another one. What will be your plan moving forward? Select all and apply. Anybody?
What do you mean, Professor? Ask it again.
Okay, so our patient
Prevention.
survived autonomic dysreflexia. Okay, so we were able to sit them up, gave IV antihypertensive medications, checked for and eliminated the cause. By that I mean, you either put in a Foley or inserted a straight catheter, drained the bladder, and this impacted the patient. Manually perform manual disimpaction. So let's say they survived, they didn't die with this episode. What will be your plan next time? What will you add to this patient's plan of care?
I guess teaching, laxatives, what? I mean,
All right. So, of course, you'll have to establish a better bowel and bladder regimen,
mm-hmm,
right?
mm-hmm.
Teach them about the other triggers, which would be tight clothing, um, yeah, sitting on their testicles, um, yeah. So, caring for pressure ulcers, they may not be aware that they have pressure ulcers, right? Um,
Can pressure ulcers trigger this autonomic dysreflexia or no?
yes, it can. Says clearly here. Here, pressure ulcer. Plus, like I said, this is going to cause pain, whether or not they feel it. It is painful. Which is the same here. Lying or sitting on a hard object, that's pain. They just don't feel it. Other manifestations of especially the severe hypertension are the following: nasal congestion, anxiety, blurred vision, chest pain, or sense of impending doom. These are all under severe hypertension. Any questions?
Nope.
Okay, so let's complete the traction. I mentioned earlier that we need to do pin site care. So here is your interventions. I mean, here's the one of the complications. So if you don't do, because these are big screws that they use to secure the halo around the skull. So this is what you do: pin site care, normal saline, but we usually use hydrogen peroxide to clean around it because saline has no antiseptic property. I mean, it will it will remove the crusting and some, drainage around there, but you need some antiseptic there. Oh, it did do, yeah, sorry. Yeah, they did use peroxide right here. Oh, it says do not be used. Okay, so erase that. I guess I'm using old practice, so they're not used anymore. Really? Yeah. Okay, I guess I'm very old now. Um, oh, one thing. So let's say you need to remove the halo brace really quickly. There is a wrench, or I'm saying there should be a wrench nearby. Sometimes we tape the wrench, duct tape the wrench to the vest. That way we don't misplace it because if we put it at the bedside, it might walk, fall on the floor, or we don't know what happens to that wrench. Because you need that wrench to remove the halo. Um, I mean, not the halo, the vest. Okay, the chest vest, because we need to remove that thing for CPR. So you have to put the wrench somewhere. Um, I'm not sure if that's the best practice, but we tape the wrench to the vest. That way we know exactly where it is. That's it. I'm not testing the surgical decompression. Um, so we'll stop right here on complications. Others are pressure ulcers on the vest where it rubs against um, in the underarm, sometimes around the neck. Okay, because if especially if there's no padding.
Yeah.
Questions?
No.
I
Like
think
2021, like what they're saying on TV.
is that a question
That's
or
what they
is that
said?
TV?
Yeah, that's what I heard. Like they're gonna have like schools stay closed till 2021.
No, I didn't hear that. So,
Miss Chisholm, what's
I
up?
hope not. That would be crazy.
you rather get corona or be safe?
Yeah.
I'm asking you.